Hi, Douglas. Thanks for coming today. Can I just ask you to introduce yourself?
So I'm Douglas Trigg. I'm a GP in Glasgow, and I have various roles within cancer, but primarily I'm one of the clinical leads for the Scottish Primary Care Cancer Group.
So we're talking about lung and pleural cancers today. Can you tell me what the key changes to the guidelines for those have been?
There is some kind of more context to the guidance now and updated data. So, for example, some more recent data showing that around 46% of lung cancer cases are diagnosed at stage 4. There's aspects within the guidance to address inequalities. And really the kind of key message to try and avoid diagnosis as an emergency is really vital. So in order to achieve that, there's been some changes to the criteria, particularly for that first step of organising a chest x-ray, which should be ordered as an urgent suspicion of cancer, chest x-ray. The actual symptoms themselves haven't really changed too much, but it's been divided up a little bit more between patients who have smoked or have a smoking history in the past, or have exposure to asbestos, and those that have never smoked. So for those that have never smoked, it's now suggesting that you need 2 or more of these symptoms, so a combination of symptoms rather than just a single symptom. So for example, 3 weeks or more of unexplained new or change in cough needs to be associated with another symptom in that list. So shortness of breath, for example. Whereas if you have a history of either smoke or asbestos exposure, you only require 1 symptom. The only kind of exception is with hemoptysis. Any hemoptysis needs to get a chest x-ray. You need to arrange a chest x-ray, but also to refer at the same time because they're likely to need further investigations anyway. Examination findings have been amended slightly, including the removal of cervical lymphadenopathy as an indication for chest x-ray. And these should be pushed down the head and neck pathway if appropriate. Abnormal radiology, whether it's a chest x-ray or if your primary care has direct access to CT, that's fairly straightforward. Again, there's been a little bit more information and clarification as to things like pleural effusion in there as well. Beyond that, another key change is that it's no longer recommended that all patients with 6 weeks of persistent symptoms, despite a normal chest x-ray, should be referred on an urgent suspicion of cancer pathway. There's a little bit more detail based on some of the evidence with negative predictive values and positive predictive values for symptom combinations. So if there's an ongoing concern, particularly if they have some of these listed symptom combinations, so for example, shortness of breath plus weight loss is one of them, or chest pain plus weight loss, these should all be considered for an urgent suspicion of cancer referral. Or if you have a direct access to CT chest, if it's available despite a normal chest x-ray. And there's a section on this in another part of the referral guidance, which gives more information about the non-specific pathways, including the importance of acting on clinician intuition or gut feeling.
I know that there's more of a focus on risk factors as well in the guidelines. What's included for lung and pleural cancers?
So I think we've touched on the 2 major ones. So obviously a history of smoke exposure, whether it's personal or a passive smoking, and also asbestos exposure, including household members of people that worked occupationally with asbestos is very relevant, particularly. There's also a risk for mesothelioma. But these guidelines kind of provide clear criteria for urgent suspicion of cancer referrals in the non-smoking population based on these symptom combinations, as we mentioned before. And it's important to recognise that smoking or risk factors aren't the only patients that should be referred.
The guidelines also include good practice points. What's included for lung in the good practice points?
So there's a clarification on what hemoptysis actually means. So it's not just kind of blood in your spit. Generally, the definition they give is that it's blood originating from below the glottis, so not blood in the saliva or from the nose or mouth or upper throat. I think that's probably the most important thing. It does touch on other parts of the referral process, and as I mentioned, overlap with other cancer pathways, and the relevance of thrombocytosis in the lung cancer, essentially, which is an indication for doing a chest X-ray in the list of symptoms. As I mentioned, there are some clinical features of overlap with other cancer types. So we've already mentioned the cervical lymph nodes, but another example is persistent hoarseness. Again, the definition of persistent hoarseness is clarified as to whether voice is never normal, it's always hoarse. And these patients may be more relevant to be passed on to a head and neck pathway if they have a normal chest X-ray. Similarly, investigations, findings like thrombocytosis, where if the chest X-ray is normal, doesn't mean that you don't have to do anything. That can be associated with a range of other cancers, and inquiry as to other relevant symptoms or other alternative pathways may be important as well.